Okay, we're going to start. I'm sure we're going to have a lot more people joining us as we move along. I just wanted to let people know a little bit of the logistics for this. Everybody will be muted except for the speakers. We are going to take questions and answers at the end. We're going to ask people to please use the raise hand function if you can. If not, you can put something in the chat, but because we have so many people, we're asking folks to the extent that you can, to use the raise hand function. Thank you all for joining us this evening. I'm Lynn Schulman. I'm running for City Council in our community to represent Forest Hills, Rego Park, Kew Gardens, and Richmond Hill. The coronavirus has laid bare the inequities of city government, and nowhere is that more glaring than in the healthcare field. I have dedicated my personal and professional life to healthcare advocacy, which was born out of the HIV/AIDS movement, where I saw a lot of my friends and neighbors die because of the indifference of those in power. And we're seeing the same thing today with the coronavirus. Queens was the epicenter of the virus. And that's because over the last 20 years, we've had 10 hospitals close in Queens, some of them in our community. In fact, Queens has the lowest hospital capacity of any borough in the city. And because of that, needless lives were lost. I have an answer to deal with that issue. And I'm going to ask people, I'm not going to go into a whole lot of detail, but I am going to ask people to go to my website, Schulman, SCHULMAN 2021.com, where I have a whole list of where there's a list of my vision for the community around that issue. And we have we're very privileged tonight to have two wonderful guests. We have Dr. Anam Khan, who is a resident, psychiatry resident at Jamaica Hospital, but I just want to make it clear that she is not representing the hospital. She is also a delegate for the Committee of Interns and Residents, which is the largest union in the country representing resident. And Dr. Khan actually worked on a COVID unit, so she has a lot of information to share with us. We also have Vincent Varielli, who is an emergency medical technician and also president of the Emergency Medical Service Union, representing officers, captains and lieutenants, and he himself is a lieutenant. He is going to talk about his experiences with COVID and also with how the hospital shortage issue and the hospital capacity issue affects you calling, when it is affecting our community when you call 911. So the first person I'm going to introduce is Dr. Khan. Dr. Khan, please take it away.
Hi, I'm Dr. Anam Khan. I'm a first-year psychiatry resident. I started my residency in July, and I've worked directly with a lot of on COVID units, on non-COVID units in the emergency room, almost every unit in the hospital. And what I think would make the most impact, what's needed is from the government with these community hospitals is to fund more staff, more doctors. There's just these hospitals just don't have enough doctors to provide the best patient care. So, which leads to a lot of the residents all to work more hours, they have more patients, and it's not really good. So I think the best thing that can be done is to just fund more positions for more residency positions, so we can have more residents working in these hospitals. That's what I think is the best thing to do. That's what's needed the most. Also, I just think that, like, even if you build another hospital or you just expand just the number of beds, but you don't provide doctors or nurses or other staff, then it's really no point. What's the point of having a building with beds and just the best equipment, but then having no doctors? It doesn't make any sense. And so that would be, in order to just, for the first thing that can do could make the greatest difference, is that to have more doctors, more staff in the hospitals. That's the number one thing that, and it's not, unfortunately, we don't see this issue. We didn't think it was real. Like when I was before residency, I didn't think it was that it would be that bad. But I've realized now, like it's pretty bad. There's just not enough doctors for each patient, and they don't really get the individual attention that they deserve, especially from these community hospitals. Um, the population which I serve is very working class. It's an immigrant population, it's minorities. A lot of them are uninsured or underinsured. They don't have access to primary care, so they go to the emergency room. So the best thing I can do is if you put more doctors into these hospitals, put more doctors into training. These residents are the most hardworking people I know. My colleagues are the most hardworking people I know. The faculty are so dedicated, but we just don't have enough residents. We don't have enough trainees. We don't have enough doctors. And the more people we train at these hospitals, they are more likely to stay in the community. I think the statistic is that people usually, like 80 or 85% of people stay within 100 miles of where they trained. So if the more people we train, the more likely they will stay in the community and serve that community. So the best thing that the government can do is to just fund more, train more people, fund more residency positions so we can have enough doctors in the hospital.
Do you want to talk about your experience working on COVID? And
So COVID is obviously can be very emotionally traumatic for a doctor, because you come in and in the morning you see a lot of patients who are very sick. Um, you have a lot of patients and you don't really know how they're going to do. One minute they're fine and then the next minute they're crashing. Wearing that PPE is really hard, and you have to wear it with every single patient, and staying in the room sometimes for a long time. It's very hot, it's very uncomfortable, it's very emotional. And then the other thing is that these patients are not allowed to have visitors. So it's very stressful that you have to update the families, and it's very emotionally so hard for them and for you. You have to give a lot of bad news, and you're not able to give good news at times. These families are not there to comfort their sick family members. So it's a lot of emotional distress. Then along with that, your colleagues, your co-residents and the nurses and the staff are all getting sick. I remember in December, so many of my coworkers got sick. Like one got sick, then another, then one comes back, then another goes. So it can be very traumatic. It can be very stressful.
so you would think that because of what happened and that Queens did have the least hospital capacity, that the government would try to fix that. But instead, what the government is trying to do, or the state government is trying to do, is make it worse. There's a hospital in Queens, in the Rockaways, called St. John's Episcopal, where the state has proposed downsizing the number of beds they have. So instead of increasing, which is what we need, and in addition to new doctors, they are decreasing the hospital capacity, leaving us all vulnerable for when we get sick. And Dr. Khan, can you talk about how what happens at that kind of hospital affects the staffing and the beds everywhere else in the borough?
Okay. What would that accomplish? Them getting like if there's less beds, then who is going to treat these patients? Where are they supposed to go in an emergency situation? And what kind of care are we going to give to the people of the borough if that happens? So that wouldn't make any sense to me. It would just lead, it would, without exaggeration, that would lead to chaos. that would lead to absolute chaos. When there's people coming in, there's not enough doctors, there's not enough beds, you're going to see literally what you see on TV, or what you would see in a developing country. You won't, it's not something that no one would ever picture happening in America, because you see bed to bed lined up, you would see people in hallways, you would see what you would see one doctor, a a young doctor, treating 20 patients, and you don't want to see that. It would look at like absolute chaos, like a war zone, and that is easily preventable. The government can easily prevent this. It's just, you need to give a little bit of attention. You can fund more positions, fund more beds, and give adequate funding, and it won't lead to such a chaotic situation like it was last March, or it was in the second wave as well, unfortunately.
And I've worked at the city's Health and Hospitals Corporation, and worked actually at a city hospital. So I've seen firsthand what happens when you have a lack of beds and a lack of staff. And it does lead to chaos. And that's what happened in Queens. We had at Elmhurst Hospital, there were 13 deaths within a 24-hour period during the height of the pandemic last March. What is a little less known is that there were 17 people that died in a 24-hour period at Forest Hills Hospital here in Forest Hills. And so that's something that we really want to avoid. And I've also seen it firsthand. I used to work at the emergency medical service, where our next guest is from. And I also witnessed when patients were brought to the hospital, what happens when there's a lack of capacity. And this is something that I have a background and experience in. And I actually wrote an op-ed about the hospital shortage, the lack of hospitals, that appeared in the Gotham Gazette. We're going to put it up in the chat, and also in the Forest Hills Post, based on the proposal to close some of the beds at this other hospital that I just mentioned in the Rockaways. Now I'm going to introduce my next guest, who is Lieutenant Vincent Varielli, President of EMS Local 3621, which represents the captains and lieutenants of the emergency medical service. And he's going to talk about some of the pre-hospital issues that occur when we have a lack of hospitals or a lack of hospital capacity. Vincent?
Good evening, Lynn. Thank you. And good evening, everyone. Thank you for coming out tonight. Yes, I have about 30 years experience as an EMT, 27 years combined with Health and Hospitals Corporation and the New York City Fire Department Emergency Medical Service. And so I've seen a lot throughout my years. And what you're saying is absolutely correct. The shortage in hospitals creates a domino effect. It also affects EMS services. When if for example, the hospital you were just talking about, St. John's in Rockaway, it's bad enough now that many times we send ambulance to Jamaica Hospital with trauma patients and so forth. And what that does is it takes the ambulance out of the area of Rockaway or the mainland area. And it takes a long time to get that ambulance back to those neighborhoods, to service those neighborhoods. If you decrease the size of St. John's or close it, it would just create chaos, because now these ambulances, when you have a shortage in hospitals, have to travel further away. And because there are less hospitals, more EMTs and paramedics will be at these hospitals, creating a longer turnaround time. So they'll be waiting to be accepted by the nurse or to be able to give their patient up longer, keeping the ambulances off service longer, packing the hospitals so they're not able to admit these patients in quickly. And it creates a real problem to service the community. I heard Dr. Khan mention a couple of things about staffing. EMS was grossly understaffed before COVID, and it continues to be grossly understaffed. We run down ambulances throughout the city, and especially in the areas of Queens and Staten Island, to name two, which is unfortunate because those are probably the two boroughs that have the least amount of hospitals. The bigger problem in Queens is it has a low amount of hospitals and a larger population. So when you have staffing shortages, both in hospitals and in EMS, you have a serious health problem, health service problems with the communities. in that borough. And, if you're sick and you need help or you're having a heart attack, a life-threatening emergency, it really is going to make a difference to your life. People will die. I also want to mention another thing that adds to the problem is that what the doctor mentioned about many people who have no insurance wind up using hospitals for their primary care. This creates a huge problem too, because if you have less hospitals available, you're using your EMS system more and more. And that means, again, more ambulances are needed to go to the hospitals. And if there's less hospitals, it's gonna be longer wait times, more ambulances out of service. And by the way, this doesn't just affect Queens, this will affect the entire city, because when those ambulances are not available in Queens, they start pulling resources from other neighborhoods, other boroughs into Queens to try to compensate. So now those areas wind up having an increase in response times, and it impacts the whole city.
No, thank you. Somebody actually put in the chat that there's a wealth disparity among the medical staff. And the administration is making money, especially at these private hospitals. Dr. Khan, do you want to comment on that?
Well, I don't really know what administration is doing. I just like to mention what the previous person said. If there's, like he said, if there's not enough, EMS is understaffed as well, and then people are using the hospital, which leads to a lot of problems, and people are using it for primary care. The other issue, which you see, like an practical example, which people can understand if there's not enough doctors in the hospital, is, for example, if there's, let's say there's 100 patients admitted who are COVID, and they are all at risk for coding, for going into cardiac arrest, and they need a full team of doctors to resuscitate them, at least five or six doctors and nurses in that room to resuscitate them. Now, during COVID, you can have situations where people can, 2 or 3 codes or even more than that can happen at one time, but there won't be enough doctors to go and resuscitate those people. Because if there's 5 doctors in one room, there's 5 doctors in another room, you've pretty much taken a good chunk of the staff, the hospital staff, the doctors in the hospital. So the third person who codes, they're going to be the unluckiest person. They might not have enough people coming and assisting them. So that's one practical example which we have to keep in mind. And I've seen this firsthand, where there's just not enough people to come in if there's multiple codes running at the same time, especially on a weekend where half the doctors are off anyways. So that's another practical example I can give of why understaffing is such an important issue.
If I can add to what the doctor is saying is 100% correct. During COVID, I don't know if people are aware of this, but because of the short staffing in the hospitals and the lack of hospitals availability, EMS was told in the field that if somebody was in cardiac arrest, especially if they had COVID, we were to work on them to try to revive them for about 20 minutes. After that, we were to call them or pronounce them dead on the scene and not transport them to the hospital, because the hospitals did not have the resources to continue providing medical care or resuscitate that patient. So what the doctor is saying is very accurate, and it actually occurred during the height of the pandemic, where many times EMS would arrive, we would work on patients, and after 20 minutes, if we could not revive them, we were told that the patient had to remain at home because there was no facilities available, especially in Queens. Everybody can remember Elmhurst was completely overwhelmed. We had tents outside and people on sidewalks. I mean, it was terrible. And, in EMS, it affected us even more so when you're dealing during the pandemic. So many people, EMS started getting sick. Not only do we have a staffing shortage, but then up to 26% of our workforce came down with COVID. So now not only you were left with the understaffing, and now you have 26% of that understaffed workforce coming down with COVID, which we saw the same thing in these hospitals. So having the availability of these beds and the staffing at a level where you can handle any emergency is very important, especially for a city the size of New York.
Yeah. The same situation happens with the doctors and the nurses.
Yep.
Unfortunately, because there's not enough nurses, there's not enough doctors. If anyone even gets sick, it just leads to even one person getting, sick. It makes a huge difference. It puts a huge pressure on the rest of the doctors.
It's a domino
Um,
effect.
yeah, it's a domino effect. Even one or two people are genuinely sick and they can't come in, it affects everybody. And as you know, when you start to the person who even has to call out sick, or has some other family responsibility for one day, feels really guilty about not being able to come to work. It leads to a huge issue. And the same thing happens when, because it's understaffed, medicine is understaffed. The psychiatry staff, the nurses are taken from psychiatry and they're put into the medicine departments, and then the psychiatry inpatient units are closed, which that's another disservice that you do to the community, because then people don't have access to mental health care. And COVID has led to a lot of mental health issues as well. People are a lot more, I see so many people in the emergency room coming for anxiety, coming with a lot of substance abuse has increased dramatically. You see a lot of, I see at least 2 or 3 suicide attempts, at least every other day. So, and then we only have one unit. And a lot of the units are closed in Queens, and I've heard even in some in other boroughs, some of the psychiatry units are closed, which doesn't make any sense. I mean, mental health it's not a luxury. It's not considered essential, as that you can just close it whenever you need to. That doesn't make any sense to me. And the part of the reason of that is, again, it's because medicine and other departments are understaffed, so they need those nurses, and they need those people to come and work into the medicine department. So none of this makes sense. It seems like there's no planning going on.
Yeah, and that's one of the things that I want to point out. A couple of people have talked about how you don't necessarily, it's just in the chat. We'll open it up to everybody in a second for question and answer, but about, you shouldn't build the hospitals, which is true, just to deal with the pandemic. One, this pandemic is going to be with us for a while. The other is that I think the main point here is that the hospital capacity in Queens, if you compare it to any other borough, particularly Manhattan, is atrocious. So there are, based on my working in the administration of a major hospital in this city, I can tell you that there are units that are closed that can be opened up. There's no planning, as Dr. Khan mentioned, in terms of what's needed and where it's needed. And that's something that we definitely need to do. We also need to, it's absolutely correct that we need to make sure that we have healthcare, preventive care and primary care options as well that are accessible to people. So that's something that's really important, because as people know, during this pandemic, the people that were most vulnerable were those with underlying conditions. And the way that you deal with underlying conditions is you make sure that there's primary and preventive care, so that those folks, there will be less people with those kinds of conditions, and we can control that. So we're not necessarily talking about building more hospitals, but I will tell you that the hospital capacity issue is a real one. I actually worked on a hospital capacity issue when I was with Health and Hospitals, and it's something that can be fixed, and it's something that can be fixed by having good planning and pulling everybody together, including the community, the medical community, as well as the community, our neighbors, and all of us here. With that, I would love to open it up to question and answer. If you want to do the raise hand function, and we can call on you, that'd be great. We're trying to, if we can not have, if you want to put it in the chat, you can. We just need to follow it to be able to follow it, but that's fine. And so does anybody want to raise their hand? I mean, there's one question in the chat, what's happening with Parkway Hospital? My understanding is that it's going to be senior housing for seniors. But does anybody else want to raise their hand? And ask a question? I'm trying to look through to see who's raising their hand.
I see one.
Hold on. Oh, yes. Mr. Mehta, you want to ask a question?
Yeah, I know there is a dire necessity to have more hospitals and more doctors. The basic question is, where are the funds and how to get them?
So what I will tell you is it's not necessarily hospitals. As I said a few minutes ago, there are units within there's a couple of things. There are units within the hospitals that we can open up. In terms of where we get the money, there's a lot of money that's in the system that we need to take a really good look at what money is being spent. There is some waste in the system. I will tell you that I currently work in the city council. And so during the finance portion of doing the city's budget, there are ways to get money. There's also been an influx, just so everybody knows, of federal monies that we got for this through a stimulus package that was passed by this new administration. So there's money from that as well, that some of which can go for healthcare. And but there is definitely money in the health and hospital system that can be used for appropriate planning such as this, so that we don't get caught short, because it's a matter of life and death for a lot of people. I don't know if Dr. Khan or Mr. Variali, Lieutenant Variali, if you want to comment on any of that.
I would just say that there's also a lot of these, so you don't have to build more hospitals. Like Lynn Schulman has stated, you can open up some units, add some beds, use the current facilities. You just need to add more staffing. And a lot of the services that are provided are charged to health insurance for people who have it, whether it be Medicare or private insurance. So these are fees. A lot of fees can be recovered from just charging for those services. And also the stimulus money that's coming in. Not only is, I believe it's about $6 billion coming to the city, but there was also $1 billion in savings that the unions have, by deferring their raises, were also given to the city. So the city is going to do pretty well as far as getting reimbursed all that money for any money that was lost during COVID. I'd like to also add, this is not just for COVID. I mean, I know COVID feels like a decade was gone by with it around, but we've had problems before COVID with the flu epidemic. We had the flu, I call it epidemic, but flu one time became a big problem as well in the city. And we had problems where we had a lot of ambulance units off service waiting and overcrowding at these hospitals in Queens, again, because there wasn't enough beds. And sometimes people had to be taken out of the borough just because they couldn't get the medical services or procedures they needed provided to them in Queens.
Yeah, I just like to add, for residency spots, it's mostly funded by federal Medicaid, but the funding hasn't increased since like 1999. And there's just the number of positions just increased by very little each year. And a lot of these hospitals, if you see, they might have approval for, let's say, to train, let's say 26 or 30 doctors in one hospital, but they really have the potential to train 40 or 45. So and that makes those extra 10 doctors that can make a huge difference. They are the ones who are going to save those lives. They are going to be the ones who come into the codes. So even those 5 or 10 doctors per year, if we train 5 or 10 more doctors in a hospital more per year, that makes a huge impact. It seems small what a 5 doctor is going to do, but no, that makes a huge difference.
Thank you. Pat Morgan has a question. Can somebody unmute Pat?
Hi there, thank you. I would just like to bring up a point. On March 28th, I went by ambulance to New York Hospital, Queens, the Old Booth Memorial, and it was determined that I needed to be admitted. I got to the ER at 2 in the afternoon. At 10 at night, they determined I needed to be admitted. I spent the next 24 hours in the ER in the middle of a logjam. Over 80 patients needed to be admitted. Now, this was a Sunday. I was there into Monday. Because of log jams, there were no beds available. So over 80 of us were in a log jam. It could take 2 hours to get a nurse's attention in the ER. I got to witness some horrific things that I don't want to witness again there. While I spent the week in the hospital actually had close to 60 people who were retired Army and Air Force and other military, and other people come from out of state working in the wards. And they came through an organization. For example, we had one woman who was an EMT from Montana, and she went around taking blood pressure all day. A retired Air Force nurse went around taking blood sugar every day. They worked from 7 in the morning till 7 at night, 6 days a week, with more energy than most of the nurses had who had only been on for 2 hours. 6 days a week, 60 people. A number of them worked on the 8th floor, which was the AIDS, not the, the COVID floor and other infectious disease.
Mhm.
And it was a horrific experience what I went through for 1 week in that hospital. And I just wanted to bring it to your attention.
Thank you. Thank you for sharing that. And that's one of the examples. Thank you, Pat, in terms of why we need to plan ahead for hospital capacity. And by the way, having worked, as I said, having worked in a city hospital, you can open up beds and you can close them fairly quickly when you need them. So if we have a plan in place of something to trigger when that happens, that would be amazing. So that's one of the things that that can be done. Does anybody else have a question? Andrew, I didn't see, Andrew McFarland, I think it was. It came and went. Andrew?
Hello, I'm actually his wife, Deanna.
Sorry.
No,
Sorry.
it's okay. Hi,
Is-
Lynn. Thank you so much for doing this. I have a quick question. I wanted to know what types of initiatives you would drive if you were elected into city council to help improve the hospital situation, particularly here in Queens, and more specifically, even Elmhurst Hospital, where, you know, it was really bad. Thank you.
Well, Elmhurst is not in the district, but one of my main tenets is to make, so right now, when there's a zoning application or the development goes up in a community, what's done is, what's required under law is an environmental assessment. So what I would do is make sure that there's a hospital capacity assessment. So that's the first thing, to make sure that we can maintain at least what we have and make sure that we can plan if a new development comes in, we're going to have more people in the community and so forth, that is made part of every zoning application. We also need to make sure, so one of the other things that I want to do is I'm in conversation, or have had some preliminary conversations. I mean, I hope that I'm elected, but I'm in some preliminary conversations around making sure that we have a public entity here, a public, either a healthcare center or something like that, that we can have in the community, so we don't just have the private hospitals in the community, because that makes a difference in terms of accessibility, in terms of people being able to come in and get all kinds of services. So that's another area, that's another thing that I would like to do. I have some, if you go up on my website, you'll see some of it, but that's some of what I would do. The other is that there are a lot of, in terms of the city, in terms of the public hospital system, the public hospital system has contracts with some of the private hospitals to have residents come or doctors come and treat patients. And so they get paid a lot of money to do that. in order for doctors to come and train at the city hospitals, because that's where a lot of the cases are seen. So we need to take a look at those contracts and make sure they're done in a way that's fair, that helps the hospitals where we need to make sure that patients are taken care of and not just go to to a private hospital's private coffers. The other thing that I am looking at as well is to make sure that we have a public health insurance system initiated in the city of New York, I think, which would also help to make sure that we can have low cost, accessible healthcare for everyone. So those are the couple of things that that I would do. Does anybody have another question? Jonathan?
Jonathan wrote the question.
Oh, he wrote the question. Okay, I'm sorry. Any numbers on the unused beds that can be opened when impact? If you look at it, I don't remember off the top of my head, but in the chat is the is a link to my hospital capacity op-ed. It says how many what the capacity is versus the capacity in other parts of the city. And so that's something to, yeah, and there's, you know what, and it's hard to say what can be open and what can't, because to be honest with you, on a daily basis, the hospital beds are opened and closed depending on what the needs are. But in general, there's usually a particular number in terms of the hospital capacity. And again, I'm sorry, I don't remember it off the top of my head, but it is in the op-ed that that is in the chat. Anybody else have questions? Yes.
I see one
Hi.
person with their hand up.
Yeah, it's hard for me to see. I'm trying to look.
Coralie Schubert is unmuted.
Okay.
Hi, thank you so much for hosting this, Lynn. I would really love to hear from Dr. Khan. I know you touched a lot on what it's been like for resident physicians during the pandemic, but I'd really like to hear about the hours that residents work even pre-pandemic, and how you think staffing would help with that and what the impact on patient care is.
So residents generally work about close to 80 hours a week. And those 80 hours are on your feet. You're on your feet for 80 hours a week. You rarely get a full weekend off. You know, most first year residents don't even get one full weekend off. The other thing is, so this has been the case before the pandemic, and what's made it worse in the pandemic is you're still working those hours or maybe even more, but there's a lot more work when you're at the hospital. So this is a huge issue. This leads to these residents, we don't have any time left for self-care, no time for family, no time for hobbies, no time. Our well-being is compromised. And I don't think this leads to better training, because I don't think that working 80 hours for 3-4 years straight will lead to better training. It's just better. It's better to have more doctors working, let's say 10-15 hours less, like working 60 or 65 hours, and you still get adequate training, but you still have some time for your own mental health. And the other thing is, you're not really allowed to, you can't even call out sick. Let's say you are, not doing well, you want to take a break, you can't, because the hospital is understaffed, so you feel guilty, even taking one day off for yourself. So that, I think, is a huge issue. 80 hours a week working for many years straight will take a toll. You'll take a hit.
Dr. Khan, Mr. Kaufman asked, who sets the standards for the hours worked by residents?
Well, the hours set standard is done by ACG, the accrediting body for residency positions. That's about at 80 hours. But the 80 hours a week, is still, it's not easy working 8 hours. I worked for 80 hours straight for about 6 months in the beginning of my residency, and I had no time for family. I had no time for hobbies. I had nothing. I literally went to work in the morning, came back home after a 13-hour shift, took a shower, maybe ate dinner, and then went to sleep. I had no, and then that one day off that you have, you obviously have to do your house chores, you have to do your laundry, you have to do your grocery shopping, all that. There's no time left for any social life or to even study. There's no time left for your social life. A lot of these residents are married, they have their own families, they don't have time for their kids, they don't have time to do any other activity in their life. And while you're at it leads to burnout, and I don't think it leads to better training. It actually leads to, I think, a worse training experience, because your brain will just stop working after a while. You're burned out. You're a human being, even though we chose to be this and we love what we do. I love what I do. I'm so blessed that I get to do this, come to work every day and care for people, but working 80 hours a week for that long will take a toll on you.
So thank you. Who can change the residency requirements? Isn't that the state, or is that still the
No,
government?
that's an accrediting body. That is the upper limit. That is the upper limit. What can practically change is, again, goes back to if there's more positions. Like, for example, if there's 25 people, 25 residents approved in a program, there has to be 24/7. They have to cover the hospital 24/7. So it doesn't matter if there's 100 patients, those 25 patients are going to work. But if there's 200 patients, it's going to be those same 25 doctors. So what change can, it's not going to be, okay, change the 80-hour work limit. That could be part of the solution, but it's not actually the practical solution. But the practical solution is, if there's more doctors, instead of 25, let's say there's 35 or 40 doctors, then those doctors will have to, let's say, work 60 or 65 hours, and then your life can become manageable. But 80 hours a week for about 2-3 years straight, or even more, is not something practical. It's not good for anyone's well-being.
So does anybody else have any other questions? Anybody else who's here? We want to give some people an opportunity to ask. Jean, did you have a question? Wait, we have to unmute you. Can we unmute Jean? Iraq? Okay, you're unmuted, Jean.
Thank you for having this. It seems so obvious. Obviously, we need doctors. How do we go about enticing more people to become doctors or get into the medical field? Is there programs out there promoting this? Is there incentives out there? Is there anything out there, trying to hook onto them?
Dr. Khan?
Yeah, so actually the truth is that there are a lot of doctors in America who just don't have residency positions. So each year people apply for residency. They have about thousands of people go unmatched, which means they apply for training positions and they don't make it. And these are qualified people who have passed all their exams. They've done exceptionally well in medical school. But just because they've completed medical school doesn't guarantee them to get a position. Why don't they get a position? Because there's not enough funding for these positions. These positions are funded by the federal government, and they haven't increased the funding since like 1999. So the number of positions has increased. We're not training more doctors, even though, so you could literally be at a Starbucks or at a retail store, and the person who's serving you could be a person with a medical degree. Because these people are left, they have medical degrees, but they're not trained, so they can't practice, and it's very difficult for them to find other jobs. So my friends who weren't able to get a training position were working at retail jobs and shopping malls. They were working as working at Starbucks to support themselves while having these student loans. And these are people who are American. They grew up here, went to American high schools and colleges and everything, and they just were not able to get a position. The most hardworking people I know. And the reason is that they cannot get a residency position. There's just not enough. So if the government wanted to, they could fix this shortage position very easily if they just funded more positions, but they're just not doing that. So I think people think that, oh, people are not becoming doctors or people not work in this area. That's not true. It's just that there's just not enough funding to put these people into the training positions.
And also, one of the things that I'm actually doing now is I've spoken to Congresswoman Grace Meng about the residency positions, because that's Congress actually is the governing body that can expand the residency programs and the residency positions. And a lot of people in Congress are not aware of that. So I'm working with the Committee of Interns and Residents with Grace Meng, who I'm very happy to say has endorsed me in this campaign. I'm working with her to get them together with folks to make sure that they can push and expand these residency programs. And Congresswoman Meng is very happy to explore that. So we're working on that now. But thank you for asking, Jean. Anybody else that's on that wants to ask anything? If not, so let me just tell you that you can, if anybody thinks of anything, you can write to me at Lynn, Lynn, at schulman2021.com, and I will get an answer back to you. If it's something pertaining to what was discussed tonight, I can ask Dr. Khan or Lieutenant Barrielli and see if we can get an answer for you. You can also go up on my website and see some of my robust platform positions on this and other issues affecting our community at Schulman, SCHULMAN 2021.com. You know, I have these forums on a regular basis, these town halls, so you can always sign up and, you know, come to them. You know, it's unfortunate that we have COVID. I would love to see everybody in person. Hopefully we'll do that soon. And I want to thank everyone for coming tonight. And I particularly want to thank Dr. Khan, who, by the way, it goes to work in a couple of hours and does her shift. So it was very nice of her to do this tonight. And Lieutenant Barrielli, it was very nice of him as well to come tonight. So thank you all very much. And I look forward to seeing you in person at some point and interacting with you again soon. Thank you.